Thank you all for joining. This is meant to be a take two of the workshop that was originally planned last weekend. And I'm Deb Siegal. I'm a thrombosis specialist in Ottawa. I'm a hematologist by training. And I have interests in, clinical and research interests in bleeding and bleeding management and now resuming anticoagulation after bleeding. Lots of areas of uncertainty. So it's good to have an opportunity to have some discussion. And we did this presentation. There's a very short presentation just to kind of get people talking about this issue. I'm very happy for people to, raise questions. Again, it's meant to be of a discussion and not really a presentation. And so again, this can be driven entirely by what people are interested in talking about. If we don't have the information that you need, I can certainly try to get it for you as well. That's part of the discussion. So it would be helpful. I know that people aren't on camera, but maybe just to let me know just who everybody is. So we have Donna, who I see on camera. Thanks, Donna. And I'm going to try to monitor the chat. Hold on here somehow. So I don't know if people want to maybe unmute and just say where they're coming from and what their background is, just to give a little help. I'm Deb Siegal. I'm a hematologist in Ottawa. How about Sue Hare?
Hi, can you hear me?
I can.
I'm a GIM fellow at UBC.
Oh, thanks for joining. Welcome. Okay, and Selene. I'm just going on my list here on the screen. Maybe Selene has stepped away. How about Khue, or Khue? You can let us know how to pronounce that properly.
People are putting it in the chat. So
people are putting in the chat? I can't see the chat for some reason. Hold on here.
Okay.
Selene's
a pharmacist in St. Catharines General. And
hi, Selene.
Yeah, who's a GIM from Montreal without a microphone.
Okay, no problem. That's fine. The chat, it works just as well. Mona? And we have Bethany and then Jerry Matthews.
Hi there.
So Jerry is a pharmaceutical rep, and I'm actually related to Linda, who's a hematologist in Ottawa.
Ah, cool. Sorry, yeah. Bethany, I skipped over you very quickly.
No, that's okay. I'm a hematologist in Kingston.
Oh, hi. You're just down the road. Nice to meet you. Meet you. And thanks, Jerry, and to Mona as well, who's a pharmacist from Guelph. That's awesome. Just nice to know who's all on the call. And then we can go. So what I'll do is, why don't we start with this case, which just to kind of get us thinking about this issue. And I'm just going to pull up my thing here. Okay. So before we do that, we'll just, I had to present, these are my disclosures, essentially. I've had honoraria from a couple of manufacturers of anticoagulants, but those are not long-standing relationships. So they were over the past couple of years. And it's also important to know that the conference in general received financial support from different manufacturers of anticoagulant drugs. And so there are potential conflicts of interest, obviously, because we are discussing some of the products that are made by those companies. But, Thrombosis Canada does do a really good job at mitigating potential bias. And, we developed the program and with a planning committee, and it's peer reviewed by Thrombosis Canada. So it's important to us to do that. Okay, so this case is actually taken or derived from a case that some cases that we presented as part of this upcoming bleeding management in patients with atrial fibrillation education program. And so it's just a little teaser for that. Then there was a scientific planning committee, which included me and a few family physicians and a pharmacist in Montreal, just so you guys know that. And so we'll just kind of set the stage here. And I'm sure, in your different clinical practices, you experience this a lot. Obviously anticoagulation is the most important / common complication of anticoagulant use. And even in 2021 with DOACs, we're still seeing a lot of bleeding complications. And I would say, although we always talk about intracranial hemorrhage, which is the most devastating complication of anticoagulants, what you commonly see is actually GI bleeding, which accounts for about half of all of the bleeds, and then GU bleeding. So hematuria is really common. And I'm happy, depending on your context, you may see different things, but these are certainly things that we see all the time. So this is a patient. This is a patient that was derived from actual patients, but is a fictional patient. So you're a family physician, or you're a pharmacist supporting a suburban family physician, and this 77 calls the office and says that he's got 2 episodes of hematuria over the past 8 hours. We get this all the time. Our thrombosis nurses take lots of calls from patients like this, and he has no signs or symptoms of infection, but he does bring in a pale pink urine specimen to the office. And if you can see here, this is a fairly representative case. This patient has atrial fibrillation. He had a history of bladder cancer, but completed treatment a couple of years ago. Some heart failure on the basis of diastolic dysfunction, hypertension, and type 2 diabetes. He also has a history of coronary artery disease, and this is important because he had a non-STEMI and had PCI with drug-eluting stents in 2015. So that was a remote event. He's been stable since then. He's taking rivaroxaban 20 milligrams and aspirin 81 milligrams every day, in addition to some other medications that you can see there. And you do a urinalysis of his urine sample, and it shows blood, and doesn't look like there's any indication of infection there. And some other tests are sent off, including a CBC and a creatinine, and he looks well. On exam, he's hemodynamically stable. He's not pale. He looks good. So I guess the question is here, what type of bleed is this? And, people can chime in, although, and I wonder, is this something you guys see in your clinical practice? Maybe in primary care, this is quite common, maybe less so for the internist or hematologist in the group. I'm seeing in this in your office, but, certainly in the community, this is really common presentation. I don't know if others, feel free to raise your hand or weigh in if you have any comments or any thoughts on this. And this is a minor bleed, really, right? So, for patients like this who present with minor bleeding, and this could be like minor hematuria or minor epistaxis that's kind of intermittent and stops on its own, minor hemorrhoidal bleeding, really, a DOAC can be continued. What I like to say is that, it's helpful to know about these events, because what you don't want, patients can very quickly progress along the spectrum of severity from minor to major. And so what you don't want to do is miss something minor that could mean that there's something more serious going on. And so you always sort of advocate for follow-up and, repeat hemoglobins and things like that. And we put here, that there is a Thrombosis Canada bleed management tool. It's helpful, and it starts with risk stratification of the patient, and then goes on from there, because of course, like how severe the bleed is really does determine, the course of action. And the nice thing about DOACs, as you guys know, I'm sure, that you can start and stop them really quickly. So you take a DOAC and you're therapeutic within 3-4 hours, and it has a short half-life. So it does facilitate starting and stopping, particularly around bleeding complications. But this, in this case, probably doesn't need bleeding. But you really do want to know, like, why is this patient having bleeding? And then this gets to the next point, which is, a couple of days later, you're following up with the patient, and now his hemoglobin's dropped to 112 from 128. He's still having hematuria, but now it's actually more severe, and he's got dark pink urine, and he's passing clots. He feels otherwise well, and his blood pressures are okay at home, but you're like, okay, what is going on with this patient now? He's still having bleeding. Obviously, something is bleeding, and so we hear this all the time. The patient is bleeding because he's on an anticoagulant, but anticoagulants don't make you bleed; they just make your bleeding worse. So you always want to know, what is the bleeding coming from, and often even stopping anticoagulants doesn't necessarily stop bleeding, because there's still something. There's a hole in a blood vessel somewhere that needs to be fixed. So for this patient, what is the most appropriate next step? Direct him to the emergency room, continue a DOAC and check the hemoglobin again before the urology consult, hold the apixaban and repeat the hemoglobin again before the urology consult, or switch them from apixaban to aspirin. And we see this quite a lot, actually. People, and we could talk about that maybe afterwards, is, people who are deemed to be a high risk of bleeding and then switching them to aspirin for the perceived lower risk of bleeding. And in fact, we know that's probably not the case based on good quality data like the Averroa study. But anyways, we can talk about that more. And so the answer here really is C, hold the apixaban and repeat the hemoglobin. Now this guy's he's dropped his hemoglobin quite a bit. He looks pretty well now, but you know that things can change pretty quickly. I'm not sure in this case, if you had the capacity to see the patient and follow up, he probably doesn't need to be seen in the emergency department, but he does need clinical follow-up, and he does need a urology consult to figure out just exactly what's going on in his bladder or genitourinary tract that's bleeding. So I'm going to leave these key learning points up, but I was hoping that we'd have an opportunity for you guys to ask your questions, and we could have some discussion around this as sort of a representative case, the patient who progressed along the spectrum of severity of bleeding. Minor bleeding doesn't really require cessation of DOACs, but it is an opportunity to revisit that the patient is on the right dose for their clinical indication, and there are some other clinical characteristics that, review their medications like antiplatelet and NSAID therapies, make sure that they're taking it properly, and then looking at their blood work to make sure nothing else is going on, like their kidney function's all right and their liver function's okay. But really, when patients progress or present with more severe bleeding, moderate, or even major bleeding, that really does require temporary interruption and close clinical monitoring, and really need to figure out what exactly is bleeding. And often we're advocating for that. In my practice, a lot of my practice is taken up by figuring out what exactly where has the bleeding come from, and that can actually be really informative. So I don't know if I want to open it up to the floor and not just, monopolize all of the discussion. If anybody else has questions about, or we can talk about other aspects of bleeding or resuming or tricky INRs or anything you guys have questions about, I'm happy to. Let's see if there's chat here. Anybody? I don't know why I can't see the chat anymore. I don't know if anybody has any questions that you came prepared to ask about bleeding. Is this something that resonates with people, that they see these patients in their practice? What do you think about resuming this guy's anticoagulation? So we're like, okay, this patient had a CHADS-VASc score of 5. The question will be, and thrombosis gets consulted, the patient is bleeding. When can we restart his anticoagulants? This is something we encounter in the hospital all the time, but even in the community is something we face that's, quite a big challenge.
Would you wait to see what neurology finds on their examination, and if there's anything that they, if they need to go to the OR for some reason, or there's something else that they need to work on, and after that, seeing how the patient's actually doing and when the bleeding actually stops. If there's no further intervention or they've dealt with the underlying issue, the bleeding has stopped, maybe after a couple of days, you cautiously start again with a close follow-up, or if they're in hospital, monitoring them while they're on that with another follow-up with their hemoglobin shortly after.
Yeah, I totally agree. I mean, all of essentially what you're saying, Suhair, is that, it's really helpful for urology to weigh in. So they'll see the patient and do, and in fact, if we kind of broaden this to a bleeding patient in whom we've stopped anticoagulants, the really important questions are, what is the status of the bleeding? I'm going to just pull something up here because I wanted to. So what is the status of the bleeding? Because again, if the person, you can't, as I was commonly taught during my training and at McMaster with lots of mentors who, the mantra was, you can't anticoagulate a bleeding patient. It's really important that I'm just going to do this here. Hold on a sec. It's really important to establish whether or not they're still bleeding. That can actually be really tricky in real time, particularly with hematuria and GI bleeding. Like, it's hard because you can't actually see the bleeding start or stop. So I've just shared a screen here that has an approach. Now, we came up with this algorithm for approaching GI bleeding, but I think the same principles apply for GU bleeding and others. Is that, if you look on the top or the right hand side, like, has the bleeding stopped is clearly the most important question. And sometimes we get asked, and I don't know if you guys have these scenarios where the patient has is perceived to have a really high thrombotic risk, like mechanical mitral valve, and so the question is, can we start a little bit of anticoagulation even though the patient is bleeding? And I think that's really tricky. And what I sometimes like to frame it as is the patient. We can't anticoagulate a patient for a potential thrombotic event when they're actually bleeding. So, what you're dealing with is the bleeding. Now, that doesn't mean that you don't reconsider anticoagulation very frequently, which is exactly what Suhair, what you had mentioned. But often there's a difference in the capacity with which you have to monitor patients in hospital and as an outpatient. It can be really challenging in the outpatient setting to follow these patients over time and to see them and to reassess them, right? So in hospital, I think you have the luxury of being able to monitor their urine in the urine container or in their Foley bag, whereas, in the community, it can be much more tricky. I don't know if other folks in primary care wanted to comment on that, but I think, again, has the bleeding stopped? Really important. And then we always kind of ask, like, do they still need an anticoagulant? I know that sounds sort of silly, but it is actually important. And we do sometimes discontinue anticoagulants because they're not needed anymore, or we've decided that that the risks outweigh the benefits, and then I think the other the considerations that you're facing when you're resuming are what is the thrombotic risk, and that can be not just the type of thrombosis. So like a DVT is different than a stroke, but the absolute risk of having that event, so what over the course of a year. So a patient will say, well, what is the risk of me having a stroke in the next year or the next month or the next week? And that can actually be really important. And then the other side of the coin is bleeding risk and whether or not you found the site of bleeding. So sometimes you find that even with GU bleeding or GI bleeding, you can't actually find what's bled. And so it's really difficult then to be able to say, what the likely risk of rebleeding is if you don't really identify a bleeding site in the first place. But certainly if something's found and something's treated, that's very reassuring. So this pathway is kind of developed, with these principles in mind. There's also, I put there on the slide, you can see Manage Anticoag, and that's an app that we developed as part of a expert consensus management pathway for managing bleeding. And they have an app, and actually it helps because it's not a guideline, but it actually goes through like the principles of, managing bleeds and restarting anticoagulants after bleeding. So I encourage you to check that out because it's quite good. Well, I mean, I'm biased, but I think it's quite good. I don't know I'm doing a lot of talking. Anybody else have any thoughts about that? There are a lot of considerations here, and no high quality evidence. So really is about kind of talking to your patient. And they're
sorry to interrupt.
Go ahead.
Yeah,
Hi, Laura.
Hi, I'm a pediatric treater, so completely. Hi. So completely different story, but wondering if in any complex, I'm talking about complex cases with tons of prothrombotic and potential and bleeding risk, if you ever use any TEG or any other global test or any other test to guide your recommendation. We have some kids that are so complex that they're bleeding, but at the same time, they're progressing their thrombotic events. I don't know if you will ever consider something like that. Yeah,
that's a really good question. I've not seen that done. We don't have easy access to TEG or other global. So Laura's asking about your pediatric hematologist, Laura?
Pediatric thrombosis, yes.
Yeah. Where are you located?
Sea Kids.
Oh, hi. Thanks. So, we don't have ready access to TAG or thrombin generation in the clinical space. Those tests, and you know this, and maybe just for the benefit of others, they're more tests of global hemostasis. So they give you kind of both the prothrombotic and coagulation, like both sides of the bleeding clotting story. And it actually so they can be really helpful in a lot of settings like, cardiac surgery, liver transplant. I don't know if you guys use them clinically. We don't really use them. It's appealing to be able to use them. And so, for example, one of our fellows is doing a study looking at thrombin generation in patients on DOACs who are bleeding or need urgent surgery and kind of measuring it before and after PCC, but it really still is in the research domain. I'd like to say it is intriguing. Sometimes we do, the other thing I wanted to, and maybe you have this experience as well, is that, again, I use that framework of like the person's actually bleeding. And so I'm very hesitant to anticoagulate for potential thrombosis. If there's actual thrombosis, sometimes you're trying your best to like negotiate a dose that may be helpful, but often, achieving hemostasis and being really gentle about re-anticoagulation allows you the opportunity to ensure that hemostasis continues. So like, it's a little bit like a pay it forward, you know what I mean? If you're gentle up front, the person stops bleeding, you can gradually resume. And sometimes if you're too aggressive on the anticoagulation side around bleeding, you end up having to hold anticoagulants even longer. You know what I mean? Yeah. But it's uncomfortable. So I think you're reassessing that daily for sure in hospital.
Thank you.
Yeah, that's not an easy question to answer. I don't know if other folks on the call had questions or face this in their own practice. One of the challenges that we face in this domain, particularly in the outpatient setting, is who owns the restarting anticoagulant. It's a very, we did some qualitative work about like trying to understand who makes that decision. Like who is responsible for deciding when someone goes back on anticoagulants, and it's pretty murky. And so some of the issues that we found and barriers to restarting anticoagulants had to do with communication, between hospital and primary care, but it's not always clear like who's supposed to follow, and then who's supposed to make the decision, and what you use to make your decision. Is it a primary care decision? Is it GI? Is it urology? Because urology isn't going to make that decision in my experience in this case, or GI isn't going to make that decision necessarily in this case. But so that can be a bit tricky.
I agree. I've seen that in the hospital a lot. People get discharged home, and in the summary it says, follow up with primary care physician, and then resume anticoagulation when appropriate, or something like that. And then now the physician is not sure what happened in hospital and how to make that decision. Then they're referred to hematology or thrombosis or internal medicine at that point, where just communicating it in the discharge summary could have saved all of that.
Yeah, I totally agree with that. And actually, when we did our qualitative work with physicians, that we did a focus group with family physicians, and they said that exact thing. Like sometimes it's really hard for them to understand, either from the endoscopy report, for example, with GI bleeding, or, from a discharge summary, like what they're supposed to do, what the risks are, like how we're, so for us, when we're making these decisions, you're like, I guess I can understand, I can understand as a thrombosis doctor the risk of thrombosis and what that looks like for the patient. And although there is uncertainty, we have some numbers around that, to advise people of their risk. But on the bleeding side, it's like you could have, there's like 75 different kinds of bleeding or whatever, and they're all different. And even within bleeding types, so like you have, GI bleeding, and then there's upper GI bleeding that was, clipped and treated, or there's lower GI bleeding that there's really not much to do, like diverticular bleeding, high risk of recurrence, and not much to do except embolization. Like it really does matter. So I think the most useful thing I think you can do in those situations is to like talk to the providers that are managing that type of problem. So, actually speaking to the gastroenterologist and asking them, well, what was bleeding? Did you find it? Did you treat it? What do you think the risk is of rebleeding is really helpful. We get this with intracranial hemorrhage all the time, because intracranial hemorrhage can be parenchymal, it can be subdural or subarachnoid, it can be traumatic or spontaneous. Like it's like totally, once you really get into it, it's not a one size fits all option. And I think often we're asked to make decisions without enough information. So I often will tell the fellows, like, if you're finding yourself really at a loss for making a decision, getting more information about what actually happened and what was done is extremely, extremely valuable. And then you don't feel as though you're plucking something out of thin air. But often I think we need to be very explicit about who is responsible for restarting, and what are the criteria that we're using to restart. Like the family physician not only needs to make that decision potentially, but how do they know when they can? And so that's really helpful when there's more communication. That's easier said than done for sure, but it's very beneficial. I totally agree with that. So Sue here in BC, do you guys have a thrombosis service that you guys make these decisions, or is it you don't really see these patients in hospital?
Yeah, there is at the St. Paul's Hospital, there's the thrombosis service, and they've just started in the Surrey Memorial as well. There's a lot more community hospitals here in Vancouver, so there isn't as much support as maybe we need, but in the bigger hospitals, there's a thrombosis service.
Yeah. And would you say that people, by and large, do you think that they go back on anticoagulants or not? It's funny, sometimes you talk to people and they're like, oh yeah, we tell everybody to go back on their anticoagulants, says GI, but in my experience, that's not the case.
Yeah, I think when I rotated through there, it was very much a decision with the patient, and just dependent on their patient preference and if they've had thrombosis in the past and what their risk was. So it was very much like a discussion with them, and depending what their bleeding event was like, it varied quite a bit.
Yeah. So we're just about to start a study too, looking at, two studies. We have a patient values and preferences study to understand how patients make that decision or what's important to patients about that decision. So that'll be cool. And then a cohort management study looking at a strategy of restarting, because one of the challenges in this space, like there's no high quality evidence. But it's also there's so few data that it's actually hard even to do a trial to randomize patients to this or that time frame or this or that dose. So it's pretty challenging. But there are resources to help, and this is a really good one. They also have this manage anticoag thing. Also has a periprocedural interruption and bridging one. We have one from Thrombosis Canada, so both of these are at your disposal. The one from the American College of Cardiology is a little bit more principle based, like things to think about as you're managing these patients, as opposed to a guideline or like a path, an algorithm. Sorry. Yeah. It's funny because the in-person meeting, there were lots of questions about abnormal INRs. Does anybody have a tricky INR question? There were lots of good, tricky INR questions. But today, no. So is there any other information that you guys would want or that would be helpful? I can always email stuff to you too if you. I'm just going to check the chat.
Could you comment on our use of tranexamic acid? I mean, there's an obvious contraindication in this case, but just maybe more generally.
Sure. You mean in the context of bleeding?
Yeah, sure.
Yeah. So actually we have, it actually is something that's come up. It comes up quite a bit in clinical practice. I think it's probably underutilized in this setting. We don't have data to support its use in the setting of bleeding patients, like on a DOAC or on anticoagulants. But we do have, and I don't know if you guys are seeing it in your clinical practices, that there's a lot of interest in using tranexamic acid as an adjunctive agent. So obviously, we were always historically concerned that about the potential increased risk of thrombosis. And actually, if you go on the up to date or the FDA, there's a black box warning about thrombosis. but really that hasn't borne out in a lot of the patient populations that have been studied. So like postpartum patients, cardiac surgery patients, orthopedic surgery patients, trauma patients who actually are all at high risk of thrombosis. And, you know, in all of those trials, in like thousands and thousands of patients, we're not really seeing a prothrombotic signal. Granted, those patients aren't patients on anticoagulants to begin with. But I think it is, like, in the absence of other types of agents, you know, and if the patient is still bleeding, you're giving them, you know, supportive measures. You're pursuing interventional treatments like to stop the bleeding. It's you know, I think it's a reasonable thing to do. You know, we in Canada, for example, for factor 10A inhibitors do not have a reversal agent. So you can use 4-factor PCC for bleeding patients. We don't really know how well it works, and we don't really know about safety. It may be helpful. We're not sure about that. But you know, if a person is otherwise, you know, quite sick, then tranexamic acid can be really useful. I don't know. Are you using it, Bethany, in your clinical practice in that setting, or?
Yeah, we use it occasionally. Probably like would want a little bit more bleeding than what this patient had, and obviously with the hematuria, you're worried about like. Oh
yeah, clots in the GU system. Yeah. GU bleeding is that one that you're not supposed to use it, right?
Yeah.
Yes.
And then we use it a lot in our like our von Willebrand patients as well.
Yeah, and that's kind of where you see it. Or, you know, the other place where we see it, and actually I was at a meeting on Saturday, there was a good talk about menstrual bleeding and heavy menstrual bleeding in women on anticoagulants. And so that's another place where we're seeing it being used, you know, short term for heavy menses. So to maintain a person on anticoagulants seems to be a reasonable approach. Again, like not a lot of data, but I think more and more people are comfortable using it. Just because of the large clinical trials that have been done, which, you know, have failed to have a thrombotic safety signal. It seems safe. I don't know if that, but I wonder if we should be using it more. It'd be nice to do a study. We were trying to look for some data at one point, and there really isn't any.
Yeah, no, that would be a good question to answer.
Yeah. Oh, there was someone in the chat. Oh, okay. So Mona, thanks, Mona. Agreed. So the reason I'm going to go back to that case there. Hold on a sec. Thank you for that. Yeah, that was part of the point of this case too, was, you know, identifying the modifiable risk factors for bleeding. So this is an area which is really common. Patients have, you know, stable coronary artery disease. This patient had a NSTEMI and stent in 2015. Most people now would support single, like monotherapy with an anticoagulant for patients like this, and so aspirin can be discontinued. Now, sometimes, depending on the type of event that they had and the type of stents and the anatomy and this and that, the cardiologist may be keen to continue. That's really, I think, the minority of cases. There are limited data about DOAC monotherapy, but certainly DOACs or warfarin, you know, for remote stable coronary artery disease is enough on its own. And yes, that will certainly reduce the bleeding risk. That's 100% true. Thank you for noticing that. And in fact, here, this is kind of the, so I think, you know, whenever you're, you know, this is a talk that I just gave, and it, you know, I really think that managing bleeding starts with prevention, which is where like primary care and pharmacy and folks come in, is that, and us in hospital is to say, okay, how can we optimize this patient of modifiable risk factors so that we're going to reduce the risk of bleeding happening in the first place? We always get asked about bleeding, but then you'd like to be able to prevent it. And so part of that is really looking at, you know, evaluating and addressing modifiable risk factors. And this should be done iteratively, like over time, in order to do that. I don't know if that's something people are seeing, but often even in our clinic, so for example, you know, a patient who had a stroke, an ischemic stroke, non-cardioembolic, like just an ischemic stroke, kind of remotely, and they require anticoagulants. And then there's always this discussion of, you know, do they still need to be on an aspirin? Who decides if they need to be on an aspirin? How do we make that decision? You know, I find that these things end up being quite protracted and difficult, but in reality, most patients should likely discontinue aspirin when they're on a DOAC for remote stable, you know, coronary artery or other arterial disease. Okay, so maybe if nobody else has other questions, I know everybody's really busy, we can end. And just to let you know, if you have any other questions, just let me know now.
Just one more question.
Oh, for sure, Laura, thanks.
About tranexamic acid and hematuria, I know it's a contraindication, but I've seen some reports of tranexamic acid being used actually to treat hematuria. So I'm not with local irrigation, maybe locally. Have you ever used that?
We have used it, maybe not in people who are on anticoagulants, but certainly people with thrombocytopenia, like ITP or something, and they're having hematuria in that kind of setting. I'm not sure that it's, you know, really all that different. I guess the concern is that you're going to get a clot and block off the ureter, and then they get, you know, acute urinary retention and etc., which is a problematic. So that's, I think, where that black box warning or whatever comes from. I have seen it used. It's not to say I have seen it used. It might be helpful to know exactly where the bleeding is coming from, and you know, if it's a man, like a male man or a woman, might make things a bit different depending on the anatomy of the GU tract, right, and where the clot can get stuck. Because big problem for men getting clots and having, you know, urinary retention and having to go to the emergency room and CBI and stuff like that. But yeah, I have seen it done, but it's not something that we do routinely. Yeah. Do you guys use it in pediatrics?
Not so much, but we have had a case in the past that had hematuria. She was hospitalized, so to me, she had a PE and hematuria.
Okay.
And so we had to stop treatment because of the degree of hematuria. I can't remember the origin of that bleeding and the reason for the bleeding, but I was thinking, why can't I just put a Foley in and get over with it and give something to stop the bleeding so I can treat the PE?
Right. And that's sometimes, like, I think, you know, it's such an important role to do that, I think, in the hospital on the inpatient side, or even on the outpatient side, but, you know, it's much more acute, I guess, on the inpatient side, is to advocate for some type of intervention. And often I find when I call, and I don't just leave a note in the chart, I often will just call, you know, the urologist or the GI person and say, you know, this is where I'm coming from. This is, you know, we have this patient who's had a PE, and the, you know, short-term risk of death is really high. We need to be able to anticoagulate this patient. Is there, I know that you normally don't do X, Y, or Z, but in this case, would you consider expedited cystoscopy? You know, they do, you know, coagulation, they can do all kinds of things. And often if you, you know, at least if you express your side, they don't always know, you know, why it's so urgent, important, necessary in this particular patient. And same thing with GI. Often they say, well, this person's stable. We can scope them later after they go home. And you're like, well, I can't anticoagulate them until we fix what's bleeding, right? So, you know, there is a role for expedited assessment sometimes in that kind of discussion. And often, you know, I think it's just a matter of explaining, you know, the rationale for why you're advocating in that way. Yeah. But GU bleeding, like hematuria, can be so tricky, really, really tricky. I don't know about in kids, but in adults, and particularly when there's like bladder or prostate bleeding, it just seems that they bleed and then they stop and then they bleed and they stop. It's very tricky with anticoagulation.
Yes, I can remember her case was she was in PICU for a long time with multiple issues. Yeah,
it can be really tricky. You don't want to put IVC filters in anybody, but certainly not children, right?
Yeah, well, we try to avoid them as much as possible.
I'm sure. Okay.
Thank you.
You're welcome. So maybe if there's no other questions or comments, we can end here and have 20 minutes of our day. I'm happy for people to email me if you do have a question or you think of something, or you'd like some sort of resource. I've got lots of stuff that I can share.
Thank you so much.
Okay, thanks everybody. Thank you.
Thank you.